Hello, ladies and gentlemen, and welcome to our presentation today. Today, we shall be looking at respiratory disorders, and we are focusing on the diagnostic aspects, assessment and diagnostic aspects. So, we have several diagnostic procedures that normally help us at least assess the lung function, detect abnormalities, and guide treatment. And these tests range from the non invasive one to the invasive ones. So before we proceed to the diagnostic test, we normally carry out some assessment, and in doing so, we could do the physical examination where we do inspection. This is what is commonly referred to as observation. As a healthcare provider, you inspect the patient's breathing patterns, chest movements, any efforts in respiratory, any signs of respiratory distress. It could be cyanosis, that is the bluish coloration of the skin on the mucous membrane. Use of accessory muscles in breathing, like the scalene muscles. So you have to note this. You also do auscultation, and in auscultation, we normally use our stethoscope where we are going to listen to our lung sounds, and this could elicit signs like wheezing, crackles, decreased breath sounds, and this will help us identify different abnormalities. We shall be able to summarize some of the commonest respiratory disorders with the common auscultatory findings. We also do PACAS, where we are able to tap on the chest to assess for fluid accumulation, masses, and even abnormal air spaces. Lastly, we'll palpate, where you feel the chest to check for tenderness, symmetry, and chest wall expansion. So let's start with chest assessment examination. Now, to carry out this procedure, you need to perform hand hygiene using liquid soap and running water. That is the recommended. Then you have to provide privacy to your patient. You have to inform the patient so as to get the consent from the patient. Remember, when you have the consent from the patient, you help allay anxiety on the patient, and the patient will be able to cooperate during the procedure. Bring yourself with a stethoscope, and this should be warm. It should be warmed stethoscope, and we shall be showing you how to warm the stethoscope. Remember, we are going to use the diaphragm part of the stethoscope to assess for high pitched sounds, bell for low pitched sounds, and also the heart murmurs. So first, before we proceed, you have to start with observing the chest by looking for any abnormalities. It could be like lesions or wounds for the gunshot wounds. Then you inspect the patient effort of breathing. You ask yourself, is the breathing labored? Are they using accessory muscles to breathe? You also look at the anterior posterior diameter, and looking at this one will help us at least rule out the barrel chest. Remember, increased anterior posterior diameter is prevalent, or it's a sign in patients with COPD. So we start by listening to the heart sounds, and here we assess the 5 anatomical points where the valves are located. We have the aortic, we have the pulmonic, the Ebbs point, the tricuspid, and the mitral point. We have several mnemonics to help us remember all these valves. Which one? The one that I use commonly is all patients effectively take medicine. Ladies and gentlemen, I know you have different mnemonics at your place. You could share with us the one that you are using and help us compare and pick out maybe the best. But for now, let us use this one. So when you're assessing all these anatomical points, you will always be listening to S1 and S2 sounds. And this is the sound you'll be listening to, right? And this is how they beat. S1, S2, S1, S2, S1, S2, S1, S2, S1, S2, S1, S2. Atrioventricular valve, semilunar valve, atrioventricular valve, semilunar valve, alright? Okay, let's start with the aortic valve. This one is auscultated in the second intercostal space at the right sternal border. So here we are saying we shall be listening to the S1, S2. So you find that in aortic valve, S1 will be softer in this area. And S1 normally marks the closure of the mitral and the tricuspid valves, okay, the atrioventricular valves, right? The valves between the atrials and the ventricles. S2, on the other hand, it will be louder at this point, and compared to the S1, right? Remember that S2 is more prominent here compared to the pulmonic point, right? And this is how it will be sounding. You can hear the first sound is softer. The second aspect of it is louder, right? So it's S1, S2. And remember, this is what you have said. S1, S2. Lambda, 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 lambda. Atrioventricular valve, semilunar valves, right? So the dub here will be more clear. I mean the S2 is the dub. So we have some common abnormalities associated with this aortic valve. We could have aortic stenosis, which is characterized by a harsh systolic murmur, and this is how it will be sounding. Right? Notice that harsh sound, right? Apart from aortic stenosis, aortic valve could also have a condition, another condition that we refer to as aortic regurgitation, and this can be identified by high-pitched diastolic murmur, followed by aortic sclerosis, which produces a quieter systolic murmur compared to aortic stenosis. The second valve is the pulmonic valve, and this one is auscultated in the second intercostal space at the left sternal border, right? At the left sternal border. You can be able to see it here, right? So at this point also, we shall be listening to S1, S2, right? Okay. So S1 will still be softer, just like in a aortic valve, and it will be less prominent in this area, and this usually represents the closure of the atrioventricular valves. S2 here will be louder, right? It will be louder, and it's being prominent than in aortic, right? In aortic, it will be more prominent than in aortic, right? Pulmonic is best heard during inspiration. So during inspiration, you will hear this sound of better. All right. Okay. So remember, we have S1, S2, lambda, atrioventricular valve, semilunar valve. So in this case, we're going to have the dub will be clear here, will be more prominent. Now, when you compare aortic and pulmonic, the dub is more clear at the pulmonic point. What are some of the conditions associated with the pulmonic valve? We have pulmonic stenosis, where we are going to have a systolic murmur that may be heard as a harsh crescendo decrescendo sound. Pulmonic regurgitation, where patients are going to present with diastolic murmur, often described as high-pitched decrescendo, right? Decreasing. Pulmonary hypertension, it can cause a loud pulmonic auscultation sound due to increased pressure in the pulmonary circulation. Alright guys, we have this common question where people are, it's where you'll be requested to differentiate between aortic regurgitation and pulmonic regurgitation. Remember, aortic regurgitation, in aortic regurgitation, the diastolic murmur is typically high-pitched, blowing sound, heard best at the left sternal border in the third or fourth intercostal space. It may be louder during expiration and may radiate towards the apex. Pulmonic regurgitation, on the other hand, we have diastolic murmur of the pulmonary regurgitation, and this is normally referred to as the Gram steel murmur. It is typically low-pitched and hard-based at the left upper sternal border in the second intercostal space. It is usually softer and may increase with inspiration, right? Or okay. But remember, both of them are what? Both of them are diastolic decrescento murmurs. The third auscultation point is located at the third intercostal space along the left sternal border, and it's here, right? Okay, this is where the diaphragm of the stethoscope should be placed to listen the heart sounds. So we're still having S1, S2, where S1 is the closure of the mitral and the tricuspid valves, while the S2 is the closure of the aortic and pulmonic valves. And all these sounds are usually heard with equal intensity at this point. So this area is particularly useful in assessing component of S2. Aortic valves and the pulmonic valve can be appreciated more clearly here. So we're going to have the S1, S2 in equal intensity. Remember, the Ebbs point is a good site to listen for both systolic and diastolic murmurs as sounds from all the valves converge here. Alright? Okay. Common conditions are associated with this point. We could have aortic regurgitation, aortic stenosis, pulmonic regurgitation, hypertrophic cardiomyopathy. Remember, this is how you're going to listen to the sound at this Ebbs point, right? In equal intensity. S1, S2, S1, S2, S1, S2, S1, S2. The fourth one is the tricuspid valve, and this one is auscultated at the fourth or fifth intercostal space along the left lower sternal border. So we're going to have the lab dub, and the lab will be more clear here. Remember, S1 will be louder at the tricuspid area compared to the S2, which will be softer in this area and less prominent. All right. Common conditions associated with the tricuspid valve. We have the tricuspid stenosis, tricuspid regurgitation, which is also referred to as the Cavallo sign, and we have the right heart failure. The mitral valve will be auscultated at the fifth intercostal space at the mid-clavicular line on the left side of the chest. The mitral valve is also referred to as the apex of the heart. So we could take the apex pulse, where you need to count for a full minute, and the normal range is normally between 60 to 100, right? 60 to 100 beats per minute, right? S1 is loudest at the mitral area. So compared to the tricuspid, you'll find that the mitral area, the S1 will be loudest, right? Because this is the point of maximum pulsation. Common conditions associated with the mitral valve include mitral stenosis, mitral regurgitation, and mitral valve prolapse, right? There is how the mitral regurgitation will be sounding. Mitral regurgitation. So when listening to lung sounds, we shall be looking at some of the abnormal breath sounds. So we'll have the patient to breathe in as you auscultate. You're going to listen directly to the skin with our diaphragm, and we listen to both the anterior and posterior chests. We are going to be assessing the pitch of the sounds, the quality, the duration of the sounds, and also the presence of extra sounds. Also looking at the chest, the chest, when you are observing the chest, the anterior chest, normally provides an assessment of the upper lobes, while the posterior part mainly provides an assessment of the the lower lobes, right? So let's start by trying to auscultate the anterior portion. And we normally start at the apex of the lung, right? At the apex of the lung, which is right above the clavicle, right? Right above the clavicle. Then we move to the second intercostal space to assess the right and left lobes. Remember, we have to locate the angle of Lewis, which is a manubrosternal angle. Then you move the examining fingers to the right and fill a gap between the ribs. This gap is the second intercostal space. So from this position, we now run our fingers downwards across the next rib and the next one, right? Then we can have it here. At least we have the sternal notch, right? Sternal notch, and then we now have the sternal ridge, the angle of Lewis, the manubrosternal point. From there, we can now move to the fourth intercostal space. And when you are here in the fourth intercostal space, remember, here you will be assessing the right middle lobe. And compared to the left side, you will still be in the left upper lobe. Remember, the right middle lobe is auscultated with the stethoscope placed anteriorly on the right at the fourth intercostal space. The right middle lobe is only auscultated anteriorly, right? Okay. Lastly, we shall be moving to the mid-axillary line at the sixth intercostal space. Remember here, we shall be assessing the right and left lower lobes. You have to remember that the axillary line is a significant anatomical point in medical surgical nursing, because it's normally used as a reference point for procedure, including the thoracocentesis and even ECG sensor placement, especially the V6 in the mid-axillary line. When auscultating posteriorly, right, we have to ensure that the patient is seated, and also we auscultate side to side and to top to bottom, and we omit areas that are normally covered by the scapula. So we start right above the scapula to the when you are here, you are listening to the apex, right, of the lungs. And then we shall now be able to move between the T7 to T3 to assess the upper lobes, and then the lower lobes will be assessed in the region T3 to T10, right? Remember, you need to find the C7, which is the vertebral prominence, right, at the back of the neck, right? It's here, right? It's here for us, the C7 vertebrae, right? Then you assess the right and lower lobes. You assess the right and lower, the right and left upper lobes, right? Okay. Then from T3 to T10, we have indicated that here you shall now be assessing the right and left lower lobes, and you can be able to see how we shall be moving. Remember, we are avoiding the spine, and we are also avoiding the regions covered by the scapulas, all right? So we are working on the part between the spine and the scapula. We have normal sounds, so we could have the first one are the bronchial sounds, and these sounds are normally auscultated anteriorly only over the trachea, and this is how they normally sound. Breathe in, out, right? You breathe in, out, right? Let's listen one more. Breathe in, out, in, out, in, out. I think you have heard that inspiration is slightly shorter than expiration, right? It takes shorter time to breathe in, and then it takes a longer time to breathe out, right? Anyway, so these sounds are normally high pitched and loud, and they're auscultated anteriorly over the trachea, only over the trachea. It's abnormal to hear bronchial sounds in the peripheral lung fields. If that happens, you need to suspect lung consultation, and a condition that can result in this case is pneumonia. The second sound, normal breath sound, is the bronchiovesicular sounds, which are heard both anteriorly and posteriorly. Anteriorly, they will be auscultated at between first and second intercostal space. Posteriorly, they will be found between the scapulae. Bronchovesicular sound are both equal in inspiration and expiration. Remember, this is be different from the bronchial sounds, where we had shorter inspiration and then longer expiration. Vesicular sound is the third normal sounds, and it's not also heard anteriorly and posteriorly, just like the bronchovesicular sound. Of course, this is opposite with the bronchial, which are only heard anteriorly. Vesicular sounds are found throughout the peripheral lung fields. So in this case, you find inspiration will be longer than expiration, which is again opposite with compared to the bronchial. The bronchial, the inspiration was short, expiration was long. But in vesicular, you're going to have inspiration to be longer than the expiration. Remember, these sounds are found in the peripheral lung fields, and we have indicated that if you find bronchial sounds in the peripheral lung fields, you need to suspect lung consultation. From normal sounds, we now go to abnormal breath sounds, the adventitious sounds. These are extra sounds. So these extra sounds, apart from the normal sounds, they are divided into two groups. We have the ones that are continuous, others are discontinuous. So for the continuous sounds, they are extra sounds that will be lasting more than 0.2 seconds with a full respiration, and they could include high-pitched polymorphic sound wheezes, low-pitched monophonic wheezes, and which are sonorous wheezes, or even the rhonchi and the stridor, right? While discontinuous breath sounds, these are sounds that are going to last less than 0.2 seconds, and they include coarse crackles, fine crackles, and pleural friction rub. Let's start with polymorphic wheeze sounds. Polymorphic wheeze sounds, we have indicated they are continuous, and so it means they last for more than 0.2 seconds. They are high pitched with musical instruments, and they are also referred to as the sibilant wheezes. They occur mainly on expiration when the patient is breathing out through, though they can also be present with inspiration as well, right? High-pitched musical sounds with many sounds. That's why they are referred to as poly, right? Many sounds associated with it. The monophonic wheezes, this one are also known as the soronous wheezes, or simply the rhonchi, right? And this is how they normally sound. Notice they are low-pitched wheeze sounds. They have just one sound quality, and that's why they are referred to as monophonic wheezes. These sounds are not cleared when someone coughs, all right? They are not cleared by coughing, and they are mainly heard on expiration. Stridor is the third continuous sound, right? Remember the first one was polymorphic, this one is monophonic, then we have the stridor, right? As examples of continuous sounds. Sounds which are heard more than 0.2 seconds. This stridor is heard only during inspiration. It's high-pitched sound, and as a harsh sound, it is monophonic, right? It only has one sound quality. Stridor is related to airway obstruction leading to respiratory distress. Stridor is normally present in conditions like croup disease and epiglottitis. Let's look at now discontinuous sounds. And discontinuous sounds, this will now be lasting less than zero point 0.2 seconds. The first one we have coarse crackles, which are also referred to as the rails. They are heard in inspiration and can extend to expiration. They are discontinuous, as we have indicated, low-pitched bubbling sounds. They can be caused by extra fluid in the lungs, which it could be associated with the heart failure, pulmonary edema, pneumonia, etc. So coarse crackles associated with fluids, all right, extra fluid. Fine crackles, on the other hand, they are high-pitched crackles, hard on expiration. We have a crackling sound, and this one does not clear again when the patient coughs, all right? And this is how fine crackles sound. Notice they are high-pitched crackles and they are hard on expiration. The other third type of discontinuous sound is pleural friction rub, and this is how pleural friction rub sounds. Notice they are hard on inspiration and expiration, and they are low-pitched, harsh sounds. Here we have the pleural layers which are rubbing against each other and can sound similar also to a pericardial friction rub, right? Remember, for the lungs is the pleural. For the heart now we have the pericardial friction rub. So how do you differentiate between a pleural rub and a pericardial friction rub? You have the patient hold their breath and note if the sound is still present, right? And if you can still hear the sound, then likely it is a pericardial friction, and this is how pericardial friction rub sounds. Notice this sound does not disappear when you hold breathing, right? Okay. So in summary, ladies and gentlemen, we have several conditions with different auscultatory findings. Like for the asthma patients, you could elicit wheezing, which is high-pitched musical sounds heard during expiration, often in both faces. Bronchitis, you could notice the rhonchi, which are low-pitched, coarse, rattling sounds heard during expiration or sometimes inspiration. Pneumonia, you could have crackles. These are fine crackle or bubbling sounds heard during inspiration, often associated with fluid or mucus in the airways. COPD, chronic obstructive pulmonary diseases, patient will present with wheezing, which are high-pitched musical sounds heard during expiration, often in both phases. Pleural effusion, patient is going to present with decreased or absent breath sounds over the affected areas. Pneumothorax, the same, decreased and absent sounds over the affected area. We could have hyperresonant percussion not over the affected area. Pulmonary edema, the patient is going to present with crackles. Remember I said crackles is associated with fluid. So crackles, these are fine bubbling sounds heard during inspiration, often associated with fluid accumulation. Pleural rub, we are going to have pleural friction rub, rattling, creaking sounds heard during both inspiration and expiration. Atelectasis, the lung collapse, you're going to have decreased or absent breath sounds over the affected area. And lastly, croup disease, patients are going to be presenting with stridor. Okay, the second part we could look at pulmonary function tests, and pulmonary function tests include tests like the spirometry, which normally measures volume and speed of air inhaled and exhaled. Spirometry helps diagnose conditions like asthma, COPD, and other restrictive lung diseases. Conditions that tests that can also help us assess restrictive lung diseases include lung volume measurements and the effusion capacity tests. Looking at one of them, which is spirometry, find that this is a common non-invasive pulmonary function test that normally measures how much air a person can breathe in and out and how quickly. So it is instrumental in diagnosing, monitoring, and even preventing respiratory diseases. How it works is that the patient normally breathes into a mouthpiece attached to the spirometry, which measures the lung function. The patient takes a deep breath in, then exhale as forcefully and completely as possible. The spirometry will record the volume of air exhaled and the speed of the exhalation over time, right? And that's what will be recorded. So we're going to have forced vital capacity, abbreviated as FVC. This is simply the total amount of air that will be exhaled forcibly after taking a deep breath, and it measures the lung capacity. Number two, we have the forced expiratory volume in 1 second, abbreviated as FEV1. And we have the volume of air. This is the volume of air forcibly exhaled in the first second of the test. It assesses how quickly air can be exhaled and is a key marker of airway obstruction. So we could now get the ratio between the forced vital capacity and a forced expiratory volume in 1 second divided by the forced vital capacity. So this ratio represents the percentage of lung capacity exhaled in the first second. A normal ratio is typically around 75 to 80%. So a lower ratio could indicate obstructive airway diseases. Remember, we can have other conditions like asthma, chronic obstructive pulmonary diseases. Here you find their airways are narrowed, and this makes it harder to exhale air quickly. So the FV, forced expiratory volume in 1 second, is significantly reduced, and the ratio between forced expiratory volume in 1 second and forced volume capacity ratio, it will be found it will be less than 70. And remember, we say that the normal is between 75 to 80%. In asthma, spirometry can also show reversible airway obstruction if repeated after using bronchodilator, and this can also help differentiate it from COPD. Because for the COPD, the spirometry will show irreversible airway obstruction with spirometry results remaining abnormal even after using the bronchodilator. But for the asthma, once you have used the bronchodilator, the spirometry findings will improve, showing that at least we have reversible airway obstruction in asthma as compared to the COPD where it is irreversible. So spirometry results will remain abnormally low. In diseases such as pulmonary fibrosis or interstitial lung diseases, lung tissue becomes so stiff, reducing the lung's ability to expand. So forced volume capacity will be reduced due to decreased lung capacity, but the forced expiratory volume capacity volume in 1 second compared to the forced volume capacity ratio will remain normal or higher, as both the FV1 and the forced volume capacity are reduced proportionally. Some conditions such as combined pulmonary fibrosis, emphysema, will be present in a mixed spirometry pattern where both obstructive and restrictive features are present. The other test is arterial blood gases, the ABG. This ABG normally measures levels of oxygen, that is the partial pressure of oxygen, partial pressure of carbon dioxide, the pH levels, bicarbonate in arterial blood. ABGs normally help analyze and help assess gas exchange and respiratory function, and it's very crucial for diagnosing respiratory failure, acidosis, and alkalosis. So we have several components of ABGs, starting with the pH, which normally measures the acidity or alkalinity of the blood. So normal range will be 7.35 to 7.45. So pH less than 7.35 will indicate acidosis, while greater than 7.45 will indicate alkalosis. Partial pressure of oxygen indicates the amount of oxygen that is dissolved in arterial blood. The normal range should be between 80 to 100 millimeters of mercury. So a lower partial pressure of oxygen will suggest hypoxemia. Partial pressure of carbon dioxide. This one reflects the amount of carbon dioxide dissolved in the blood, providing insight into respiratory component of acid-base balance. The normal range is between 35 to 45 millimeters of mercury. Higher partial pressure of carbon dioxide indicate respiratory acidosis, while lower partial pressure of carbon dioxide indicates respiratory alkalosis. Bicarbonate ions represent the metabolic component of the acid-base balance, and it's usually regulated by the kidney, so that the normal range is between 22 to 26, and increased bicarbonate ions suggests metabolic alkalosis, while decreased bicarbonate indicates metabolic acidosis. Oxygen saturation represents the percentage of hemoglobin that is saturated with oxygen. The normal range should be 95 to 100. Decreased saturation will indicate insufficient oxygenation of blood, which will require oxygen administration. Base excesses reflects the amount of excess or insufficient bicarbonate in blood. The normal range is between -2 to +2. So positive values will indicate metabolic alkalosis, while negative will indicate metabolic acidosis. The other test is the chest X-ray. So this one provides an image of the lungs, the heart, and the chest wall. It helps identify conditions such as pneumonia, TB, pulmonary edema, pulmonary effusion, lung cancer by showing areas of consolidation, fluid, and abnormal masses. So X-ray in nature, it's non-invasive imaging tool, and it can be used to evaluate lungs, heart, and chest wall. It provides diagnostic information about various conditions and is often one of the fastest ordered when respiratory disease is suspected. So the patient will stand in front of an X-ray machine, and two views will be typically taken. That is the posterior anterior, the PA view, and the lateral view. The X-ray machine normally emits radiation that passes through the chest, capturing an image based on the different densities of the tissues in the chest. Air-filled structures like lungs will appear dark, that is radiolucent, while denser structures like bones, ribs, spine, the heart will appear white, radio-opaque. Fluid or soft tissue or thickening such as infection or tumors will show up with varying shades of gray color. So if somebody is having pneumonia, the X-ray will show some consolidation, that's whitening or opacity in one or more lobes. So X-ray will help localize the infection, could it be lobar, broncho, or interstitial pneumonia, and it will help guide treatment and monitor progression or resolution. If a person is having a chronic obstructive pulmonary disease, the lungs could be hyperinflated, flattened diaphragm, and increased retrosternal airspace. X-ray can therefore help detect overinflation of the lungs as a sign of chronic obstructive airway obstruction, and also identify complications associated with it. Pulmonary edema, we could have diffuse alveolar opacities, while commonly used to diagnose pulmonary edema related to heart failure or fluid overload. Pulmonary effusion, we could have fluid appearing as homogeneous white area in the lower parts of the lungs. Pneumothorax, we could have a visible line with no lung markings beyond it, indicating air in the pleural space. Lung cancer, you could have solitary pulmonary nodules, masses, or irregular lesions with possible calcification. Interstitial lung disease, we could have diffuse reticular or nodular opacities, right? Tuberculosis, you could have nodular opacities. Chest ray is key in diagnosing pulmonary TB, and also monitor treatment progress. Pulmonary embolism may also show indirect signs of the Westermann's sign, that's the follicle oligamia, or Hampton's hump, the wedge-shaped opacity, or the pleural effusion, right? Next, we have computed topography, which is more detailed than X-ray. Then you can have the MRI, the bronchoscopy, sputum analysis, oximetry, VQ scan, exercise trace, pleural fluid analysis, that is the coracocentesis, and the positron emission topography scan, allergy testing, and cartography. Gene expert can also be used to detect Mycobacterium TB and also resistance to rifampicin, right? Okay. TB skin test, which is also referred to as purified protein derivative test. This one is used to screen for latent or active TB infections. Chest tube insertion can be used to treat conditions like pneumothorax, hemothorax, pleural effusion, and emphysema. So you have to make sure that you prepare the equipment well before the procedure, and you also prepare the patient. Remember to look at the drainage observation, integrity, tubing, vital signs, and the dressing changes, and also position the patient in an upright to facilitate drainage. Ensure that you could troubleshoot, like if you don't have fluctuation in the water seal chamber, this could indicate clots or dislodged tubing, while constant bubbling in the water and water seal chamber could indicate air leak. Chest tube dislodgement, you need to cover the site with sterile dressing tapped on 3 sides to allow air escape. If no air leak, you apply an occlusive dressing. Disconnected tube, you clamp the tube temporarily and or submerge it in sterile until the system can be replaced, right? Remember to never clamp the tube during transport or patient movement, as this will cause tension pneumothorax. So I have thoracocentesis, brachoalveolar lavage, and the biopsy, where we have the lung biopsy or pleural biopsy. Pleurodesis, which is a procedure used to prevent recurrence of pleural effusion or pneumothorax by that is causing pleural layers to adhere to each other, right? Peak flow measurements, which is used in conditions like asthma and monitoring their severity. We also have the continuous positive airway pressure, the CPAP, and BPAP, okay, bi-level positive airway pressure, right? All of them are non-invasive ventilation strategies used to maintain airway patency and improve oxygenation in conditions like obstructive sleep apnea and respiratory failure. You also have pulmonary angiography, which is a specialized test used to visualize blood vessels in lung and detect conditions like pulmonary embolism. And now we have like common conditions like tuberculosis, where you assess by first of all looking at carrying out the history and clinical examination. Of course, in examination, you will always listen to the fine crackles, which will be located in the upper lobes on inspiration. However, you could also do sputum microscopy and culture, where sputum smear microscopy, you look for the AFB, okay, the acid-fast bacilli. Remember, presence of AFB will indicate TB infection. You could also do sputum culture, where you find Mycobacterium tuberculosis culture, and this one is the gold standard for diagnosing tuberculosis. You could also do automated culture system, which normally reduces the time, because though the sputum culture is the gold standard and more sensitive, it normally takes several weeks for us to make that diagnosis, right? So we could use automated culture to try and bridge that problem. Molecular testing like Gene Expert can also be used, and when you're using Gene Expert, is able to detect Mycobacterium and also detect rifampicin resistance in less than 2 hours. Chest X-ray findings could also be helpful, where you see the upper lobe infiltrates, lesions, nodules, pleural effusions, lymphadenopathy. These findings are normally suggestive but not confirmatory. So you have to do the culture, which is able to give us exactly. Tuberculin test can also be used, and this one is just used to show the people at risk. Interferon gamma release ESA can be used in those people who already have BCG vaccination. Bronchoscopy with brachioalveolar lavage can be used in people where sputum samples are inadequate or unavailable, like in children where it's very difficult to get a sputum. Extrapulmonary TB, we could use pleural or peritoneal fluid analysis and also biopsy. All right. Remember, if you are sick and you are diagnosed of TB, all right, pulmonary tuberculosis in Kenya, you normally put on treatment, and this treatment sessions involves two sessions where we have the intensive phase and the continuation phase. The intensive phase takes about 2 months, while the continuation will be 16 weeks. So in intensive phase, you are given 4 drug regimen, which is normally abbreviated as the HRZE, where you're given isoniazid, rifampicin, pyrazinamide, and ethambutol. And the objective of the intensive phase is to rapidly reduce the bacterial load, prevent development of drug resistance, and reduce the infectiousness of the patient. The continuation phase, which normally takes 4 months, you will be put on 2 drug regimen, abbreviated as HR, where it is isoniazid and rifampicin. Remember, the continuation phase focuses on eliminating the remaining bacteria to prevent relapse. Ladies and gentlemen, we have several tests which are normally used to diagnose respiratory disorders. I'll urge you to go through the presentation and attempt free quizzes in the description section just to test your understanding and cement your knowledge.